Good morning, everybody.
Morning.
All right, why don't we just go to this one? Okay. So this is a patient who is in the EP laboratory and is having right atrial pacing at cycle length 280 milliseconds. And my question for the panel is, what do we think is going on here? So why don't we go to Dr. Marshall. Molly, do you have any thoughts on what we're looking at here?
Good morning. Let's see. I am not sure.
Okay, so I'll let me add one thing. So look at the 12 lead up top, or the 4 leads.
Yeah. Mm-hmm.
Anything changing here? This is rapid atrial pacing.
Your
On 280.
QRS looks much narrower about halfway through.
Agree with that statement, 100%.
Trying to see what else I can see. But I'm not fully sure why.
Okay. Do you notice anything happening in the coronary sinus catheter? So this is the A pacing. So these are all the A's, right? And these are all the V's, right? And again, we're A pacing. So what happens when you start to get the narrow QRS, which I agree with you, it is narrower here. This happened to the AV time.
Looks like it got longer.
Yeah, fully agree with that. So do we know any of any conditions where the ventricle might get excited earlier and then get excited later? I'm sorry?
Like pre-excitation, you mean?
Yeah.
So this could be like Wolff Parkinson White then.
I agree with that. Good. And can you tell, so what does this tell us? So what's happening now that we know this is WPW? What's happening on the left-hand side of the screen, and then what's happening on the right-hand side?
On the left-hand side, you're using your accessory pathway. So you're having like your pre-excitation, which is why we're seeing the wide QRS.
Yep.
And then later, you're not, as we're seeing the QRS narrow. And if we're at a cycle length of 280, is that telling us that's kind of around, in terms of thinking of like the high risk and low risk pathway of, or types of Wolff Parkinson White, that it's around 280?
Right. So how would you describe 280? So at 280, we stop conducting via the pathway, right? Pretty much exactly in the middle, almost in the middle of the screen.
Yeah.
So how would you, if you were describing that and you're writing your report about the characteristics of this pathway before you describe the hopefully successful ablation, how would you describe this?
I'm trying to remember is it 260 is like, if it's lower than that, it's considered high risk, or am I way off on that?
No, you're not way off, only a tiny bit. It's 250.
Okay.
So cycle length 250 is generally considered the line in the sand for high risk versus low risk. Or I should say high risk. Let me rephrase that. It's the line in the sand for high risk. And 300 is usually any ERP, or I should say any shortest, we would call this the shortest pre-excited R to R interval. And that sometimes is abbreviated as the SPERI, SPERRI, shortest pre-excited R to R interval.
Mm-hmm.
So in this case, we would say the Sperry, or the shortest pre-excited RR interval, is 280 milliseconds. So we know that, as a general rule, we believe that if you block at cycle lengths longer than 300 milliseconds, we would call you low risk. And if you block at cycle lengths shorter than 250, we would call you high risk. So this patient kind of ends up somewhere in the middle.
Mm-hmm.
Is not high risk, but is not low risk either. And unfortunately, this is probably the most common zone that most patients end up in. Sometimes we get high risk, of course, and sometimes the pathways are very wimpy and don't conduct at all at faster rates. But in this particular case, we would say that the Sperry is 280. Now, you should know that when it was determined, like when people were talking about how to determine risk, the way in which it was really originally described was through the induction of atrial fibrillation. So in the late 1970s, very famous electrophysiologist named George Klein in Canada published a paper in the New England Journal in which basically they took sort of survivors of cardiac arrest with WPW, and they brought them to the cath lab and they put them into AFib, and they were able to actually demonstrate that the patients who had, or they took a large group of WPW patients, they essentially demonstrated that if in AFib you conducted at cycle length shorter than 250, you were considered high risk for potentially for sudden cardiac arrest or sudden cardiac death. And so we use rapid atrial pacing as a surrogate for that. It may or may not be true. Also, of course, we do these procedures under general anesthesia in pediatrics, and so we don't really know if the anesthesia itself could be lengthening the ERP of the pathway. In other words, this may not reflect what happens in real life. And there are, unfortunately, a handful of cases in the literature of people who passed their testing during EP study to go on to have cardiac arrest. So it's, on the other hand, if you look at all comers who have testing, a fairly good percentage of them end up quote unquote high risk. But we know, for example, that it's very unusual for people with WPW, at least children, to die suddenly. So clearly our testing is not optimal in terms of prediction. But by classical standards, I guess we would say this person is sort of intermediate risk. In a case like this, we would probably try to put the patient into AFib because, one of the things that is disturbing, if you look in the beats that are pre-excited, do you have any sense of where this accessory pathway might be located? Where is the earliest ventricular electrogram? So again, we're going to look here. The pacing is all A, and the V. And the V is coincident with the QRS. So A, V, A, V, and then we have A, and then this is the hiss, right? V. So which is the earliest V on the left-hand part of the screen? It's really in the hiss, right?
Right, yeah.
Right. See how, so these are the A's and the V's are almost on top of it.
Right on top of it, yeah.
Right? They're really, really tight. And that now normally the hiss V would be the earliest V also, right? Because normally without WPW, we should be conducting via the AV node. And so the earliest V on the intracardiac electrogram should always be the hiss V. But in this case, and in fact, when we're not conducting through the pathway, we see that maybe these V's are 5 milliseconds earlier than the V's in the coronary sinus. Sometimes in small children, these two catheters are very close to each other, so it's not shocking. They might be competitive with each other. But here, I think we would agree, right, that these V's in the hiss are clearly earlier than all of the coronary sinus V's, right? They're like maybe 100 milliseconds earlier. The other thing that's interesting is that once we block in the pathway, we see very clearly a beautiful large hiss on each paced beat. But when we're in pre-excited sinus rhythm or apaced rhythm, we don't really see a hiss very well. That's always a very frightening sign for the electrophysiologist, because it means that the pathway must be very, very close to the AV node His bundle Purkinje system. Because if you don't really see the His in the paced rhythm with the WPW, but then we block the pathway and we see a big His there where we could not see one before, that's usually a pretty good sign that the pathway is going to be pretty darn close to the compact node and to the His Purkinje system. So that is, this would already get the electrophysiologist juices flowing a little bit, that we're at risk here, and that this is going to be a dicey ablation. This tracing comes from a number of years ago, and we were actually able to ablate this patient. So anyway, an interesting tracing nonetheless. Very good, Molly. Not an easy tracing to interpret. Cold on an early Monday morning. Okay. So my question for the group is, what is this rhythm? And also, what's going on in the atrium? So I'm going to ask Mahmoud if you have any thoughts on this.
Good morning.
Good morning.
I believe the QRS looks wide.
I agree with that statement fully.
Only
I
two.
should give you the patient's
those...
age. It's a teenager.
Okay. And it looks like a paced rhythm. I'm not sure if those spikes are like pacing spikes in front of each QRS. And the heart rate also is like 60, which is on the lower side as well.
Little less than 60, but yeah, about 60.
And it looks like a unipolar pacing as well.
Okay, so you're saying it's unipolar because you can see the pacing spike, is that right?
Yes.
Yeah, I mean, it's possible, but although I've emphasized that point in prior conferences, I think that's always a good thing to think about. Some EKGs, you can see bipolar pacing spikes, and these are not gigantic. Usually when we have a unipolar pacemaker, the pacing spike is very, very large. It almost bleeds into the other leads above and below it. So I think it's a good point that it might be unipolar. But the other thing I would always caution you or remind you is, in 2023, most of the time, our pacemakers have bipolar leads. Now, we have a baby presently in the hospital who has a unipolar leads because the baby is very, very small and the surgeon didn't want to. It's interesting, but the unipolar epicardial pacemaker leads actually come shorter than the bipolar. That was the reason that our surgeon chose to put in unipolar, because they didn't think there was enough space to put all that extra slack. But in general, in 2023, most of the time patients are bipolar paced, although there are times when we do put in unipolar, as I just described, and then sometimes the bipolar lead breaks and the lead is used in a unipolar fashion. So yes, you're right. This could be unipolar pacing. It happens that it's bipolar, but it's a good point.
And I'm not sure, but I think I only see like V pacing. So it could be like asensed and V paced.
Well, if it were asensed and V paced, would we see P wave?
I don't see a P wave. Yeah, exactly. I don't see a P wave.
Right. So is this a single or a dual chamber device or program, you think?
I would say a single.
Right. I agree with you. I think this is a single chamber V pacing.
And also each QRS is paced, so it looks like the patient is mainly counting on the pacer. I don't see any, I would say, a sinus or spontaneous QRS. So his heart rate is 60, all the QRS are paced, so most likely the pacemaker is set to a lower limit of 60.
Right. It's actually a little slower than 60. I think it's 55, but that's right. Okay. What's going on in the atrium? So I agree. This is V pacing. It's probably either VOO or VVI pacing. And probably the lower rate limit is at like 55 or something like that. But what's going on with the atrium?
I don't know, actually.
Right. It's a little
yeah, I don't see any P waves.
Right. That's right. This patient, I don't see any P waves either. I mean, you might convince yourself that this U wave here is a P wave, but it really is not. So this is an interesting case of somebody who has, we talked about this a couple of weeks ago. This is somebody who has atrial standstill. So they have VVI pacing in the setting of atrial standstill. And some of you may have listened to the podcast we did a couple of weeks ago, but there are a bunch of different conditions that can cause atrial standstill. But the bottom line is that in all cases of atrial standstill, it's very difficult to place an atrial lead because, first of all, oftentimes it's very scarred. So it's not uncommon that there's only one or two very small patches where one can actually capture the atrium. And then it's not clear, even if you could capture part of the atrium, if it's hemodynamically or electromechanically doing anything. And in that article that we reviewed, the investigators recommended that before you go to put an atrial pacing lead in those patients, it might not be unreasonable to do a carto map of the atrium, looking for areas where there's scar and where there is active myocardium. But I think in that study, like only about maybe 10 or 15% of patients were able to get an atrial lead. And of those who got one, like half of them started to fail very quickly. So I took away from that if you have a patient with atrial standstill, probably is not worth the effort and the benefit of putting in an atrial lead, because they will eventually lose capture. Even if you can gain capture, you will lose it. So anyway, this is an example of a person who has atrial standstill and is VVI paced. And any concerns, Mahmoud, in terms of patient with atrial standstill and thrombosis risk? Do we need to anticoagulate such a patient if they are VVI paced and have, there's no holes in the heart, and they have basically no atrial activity or very minimal atrial activity?
I remember on the podcast you were focusing on this point.
Mm-hmm. Okay, let's see if you remember what I said.
I think, if I remember correctly, you were concerned about having these patients, and they had like high risk of thrombosis, especially with all this no atrial activity, I would say, or the standstill. But I think the point of thrombosis, at least what you discussed on the podcast, was somehow controversial, but I do not remember the details.
Yeah, I mean, basically what they said was if you have atrial standstill, you should be on real anticoagulation, whether it's warfarin or a more novel DOAC or NOAC agent, that the risk is very high. Probably aspirin is inadequate. And I actually take care of 2 patients with atrial standstill. And when I read that paper, I was pleased to see that that was the right thing to do, because we have had those 2 patients on a DOAC actually for many years now. And they've been, thankfully asymptomatic from that perspective. Hopefully will remain that way. All right. Very good. Not an unusual tracing for Monday. All right. This is an interesting rhythm. This comes from an old EP conference from like 20 years ago. At that time, we didn't have the technology of boxes and lines on EKGs. So anyway, why don't we ask Dr. Zawani, any thoughts, Tarek, on what's going on here?
Yes, good morning, Dr. Pass. So
And now since we don't have blinds, or let's say for the sake of this discussion that the atrial rate is about 70.
Okay.
Just, sorry, we didn't have that technology back then.
Yeah, so looking at the lead 2 at the bottom, I think it's Mobitz 2 because the PR like gets longer, and then I see the a drop beat and then followed by another one.
So if the PR gets longer and then you get a drop beat, is that Mobitz 2? So complete heart block, right? None of the beats conduct. That's clearly does not seem to be the case. First degree, we have a long PR interval, but every atrial complex is conducted. Second degree, some are not. And we have Mobitz 1 and Mobitz 2. So is this Mobitz 1 or Mobitz 2?
Sorry, the second degree with Mobitz 1. Yeah.
I would agree with that, but then what's happening over here?
Yeah, that's the one I kept looking at because the P wave is very close to.
So the atrial rate isn't changing that much, right? It's pretty similar. But so it's hard to know what's going on the right side. But, you know, this could be. So we always say there's sort of, let's say, 3 types of second degree heart block. There's Mobitz 1, there's Mobitz 2, and then there's 2 to 1. And 2 to 1 is probably Mobitz 1 or Mobitz 2, but we can't sometimes tell because we don't have a His catheter in place. So this clearly looks like a Mobitz 1 pattern, right? With the prolongation of the PR till we drop it. Then we have this P wave, which comes in at a point when we were about to have a junctional beat. So we can't really say that this is not conducted. I mean, it isn't conducted, but we can't say that's because of conduction problem, just that the sinus rate is slow. Then we have this beat here, which we don't know why it's not conducting. It's clearly should conduct. It's not that fast of a rate. Then we have another P wave that falls again at the time of a junctional escape beat, and then a beat again that doesn't conduct. So this patient clearly has some AV nodal injury or disease of some sort. But, you know, the important point, I think, is if we see a little bit, so if we had only seen this, you might make the argument that this is complete heart block, right? Because we're not seeing any beats conduct. But this shows that we do have some conduction. So I think we would call this Mobitz 2, and although Mobitz 1, and although this is hard to ferret out, you know, you generally would hope that one diagnosis could explain everything. So probably this could be some form of Mobitz 1, but without a His catheter in place, we wouldn't know. But if you followed this long enough, you probably would figure it out if we had a longer strip. Okay, so you are called to the bedside because there is a patient with tetralogy who had a repair that night, and the bedside staff is concerned about the heart rate. Let's say, for the sake of this discussion, that this is 170. So Maya, the astute bedside nurse, has performed a 12-lead electrocardiogram, and this is the tracing you have. So how are you going to interpret this, and what are you going to tell the staff about your expert opinion on this?
All right. So, you know, hearing the story, I think I'm most concerned about Jet.
Very well stated. Yeah, that's exactly what you should be always, when you're asked about a case, in your mind, you should ask yourself, what am I looking for? And that's exactly right. That's probably the most important postoperative tetralogy arrhythmia we would be worried about. So good thought.
But, I think looking at this tracing, I think I do see P waves. I think they're kind of within the P wave, so they can be hard to make out, but I do see like a little deflection before every QRS. So
yeah.
I'm inclined to say this is a sinus tachycardia.
That's exactly right. This is an example of just plain old sinus tachycardia in a person who has tetralogy repair. And, I think you said it exactly right, Maya, which is that, and this is sort of the point of EP conferences, that it's useful to have a baseline understanding of what you can be worried about, so that when you're looking at tracings in patients, you're looking at them from the perspective of what is most commonly seen in patients in a given clinical situation. And so, as you astutely pointed out, if you're looking at a patient who has tetralogy and is a post-op, and people are worried about a heart rate being elevated, the first thing you would want to ask yourself is this jet? And I think you're absolutely right. I think if we look in lead 1 and in F, we clearly see that there's a little P wave. You can see that P wave in pretty much all of the leads. Is some of them easier than others, but I think I would certainly agree with you that there is a P wave before each and every QRS. I think I've told you guys that we wrote a paper many years ago in which we looked at what leads the easiest to tell, and number 1 lead was V1. The second most common useful one was lead 3, actually. In fact, I think we decided that if you could look at V1 and lead 3, you would get the diagnosis right about 95, 98% of the time. That's important because it probably means that even though we typically display lead 2 on all of our cardiac monitors, probably V1 or lead 3 are better. Now, in an early post-op patient, the precordial leads may not be in an accurate position intentionally because of an interest in staying away from the sternal wounds. But the limb leads should always be the same and should be easily obtainable in any patient. And I think in this case that, if we had just had this lead alone, we could tell pretty clearly that this patient is in sinus rhythm. This is sinus tachycardia. And then, of course, you want to just look for reasons for why the patient has sinus tachycardia, things like sedation, fever, pain. All of these issues can potentially maybe too much inotropic support, whatever the case may be. Any of these can be a potential cause of sinus tachycardia in a postoperative, an early post-op patient. The other way that you could confirm that this is sinus is to look at the intracardiac tracings, particularly at the RA wave, the RA pressure wave. And if it's a very consistent one without the presence of canon A waves, that would also be highly suggestive of it being sinus and not an arrhythmia like jet. In jet, we typically have AV dissociation, not always, but oftentimes. And so there's often canon A waves, and the atrial pressure tracing is very variable. In this case, we would expect it would be very, very stable and consistent. All right, any questions about that? Nope. Okay, I think if that's the case, we're going to stop at this point. Thanks very much, guys, for joining, and I'll see you at sign out. I think actually we're going to do sign out in the conference room today. So,
okay,
I will see you there. Take care.
Sounds good. Thank you.
Bye.